So that's a great question. So that's one of the things that impacts what the underlying myeloma genetics very likely plays a role there. Other things, the patient's individual immune system could potentially play a role. The patient's myeloma's sensitivity to the medications that patient's on at that time could play a role. So those are all the questions that we're asking also.
Anything to add to that?
It's all these issues that we talk about prognosis is really a way physicians are attempting to do forecasting. And the forecasting, of course, that you're most familiar with is weather forecasting. And when they say on the news that it's going to rain in Atlanta, they don't say it's going to rain in Atlanta. They say it's going to rain with a percentage likelihood. And even if it's going to rain in Atlanta, I don't know if it's going to rain in Augusta or it's going to rain in Buckhead. These are attempts to try and understand the likelihood. And so, sure, what Dr. Kaufman's saying is forecasting is imperfect. So you would hear, oh, I'm MRD negative, that's good. I'm MRD positive, that's not good, and that's wrong. Because those are just averages. And I suppose if you took 200 patients, MRD negative will do better than 200 patients MRD positive. But once we drill down and to one patient who says, oh, I'm MRD positive, how am I going to do? I think most of us would be pretty circumspect about trying to forecast what lies ahead. And again, the weather people will tell you what is going to do tomorrow. You start asking them, well, what's it going to do next month? Right? And now I'm hearing, well, am I going to stay in remission for 5 years or 10 years? And I think we're just about as accurate as they are. And so that's why you end up with this monthly or every 3-month surveillance, because we're not sure and we can track. If we were sure, it'd be, okay, I'll see you in 3 years. No one's getting that. Nobody's going to be off the hook that long because we're that uncertain, and we can only speak in very broad terms on those averages.
Okay, so the first question is that if you are, and we'll just say, your myeloma is not responding to the combination of Revlimid, Velcade, and dexamethasone 2 years ago. Now, 5 years later, would I treat you with Revlimid, Velcade, and dexamethasone? No, I would not. Second question, is Bella, that's the GSK compound, does that preclude you from participating in other CAR T cells? It precludes you from participating in a number of the current crop of CAR T research protocols, but not all of them. And this is where Spark Cures, et cetera, this clinical trial search engine that's made for myeloma patients that can help you figure out which CAR Ts yes, which CAR Ts no.
Nothing's with this disease is simple. And, you know, this whole weed analogy is a grotesque oversimplification. And in fact, when this disease starts out, there's probably 5 varieties of weeds in the garden. And those different weeds are different responsiveness, different growth rates. You know, if you look at it very simply, let's say there's 2 weeds, 2 types of weeds. Like this super sensitive weed population that's 90% of the weeds. And then a very resistant weed population that's 10% of the weeds. And you start treatment and 90% of the weeds vanish in a week. And everybody's jumping up and down saying, you've got a 90% reduction in your weeds. You've got a very good partial response. But what you've got left behind is a kind of angry weed population, and that could cause serious problems. So then you try and treat those angry weeds with a different thing, and you're successful. but you don't know actually 2, 3, 4 years down the line what's growing back. Whether you're growing back even a more aggressive population or the original ultra-sensitive population is growing back. There's a lot of Darwin survival of the fittest going on in myeloma, where the myeloma populations are competing with each other for survival. And it's possible that 3 years ago you got a 3-drug combination that completely stopped working, and 3 years later, it wouldn't be my first choice. Clinical trial would clearly be the choice, but you never know what grew back and what it's made out of and what's worth trying. It's really a very complex decision process.
I think so. I think that, I mean, certainly it's hard to argue with that. But I would say is that when we're out of options, we're in a large part we're not out of options, and so your question was, can you try? And the answer is we will. Yeah, we go back to the well. We go back and we try. We mix and match. Maybe he finds magic in the ink, and he's got the right combination that hits it. With the new drugs, maybe we can reactivate Revlimid or one drug by having. There's no data behind that. It's hope. It's all hopeful. But if somebody's clinically okay, we're going to go back and try to mix and match and find a combination.
By the way, there are other CAR Ts that aren't BCMA. So
Correct.
anything that's non-BCMA, my best guess is it wouldn't exclude patients who receive Bella
Correct.
from a non-BCMA CAR T. Sorry, that probably lost you all.
So what he's trying to say is
Use the meat description.
no, actually, I'll use a different one. But for the CAR T, and is it going to exclude you from CAR T studies or not? Like we mentioned, there's proteins on the surface of the cell, and certain CAR Ts are targeting specific proteins there. So if there's a CAR T that's targeting a different protein on the surface of the cancer cell, it wouldn't exclude you for that. Now, in terms of would you reuse prior therapy, I would agree that possibly yes. There's several factors. One is how long, when you use that treatment, how effective was it and how long did it keep you in remission? If it was a very good drug that kept you in remission for several years and then you haven't had it in a long time, I would consider it if I don't have any other options. The way we need to think of myeloma is it's not just one type of cancer cells, it's a whole variety or different flavors of cancer cells. So if you have a group of kids that are friends, there's always the leader, and then everybody else follows suit of what the leader does. But in that group, you're gonna have the leader that's calling the shots, and then you're gonna have a kid that's mean, and a kid that might be easygoing, and a kid that just follows whatever everybody wants. And there's all these different personalities. But the leader's the one that's calling the shot, and everybody follows suit. In myeloma, it's the same thing. We have a whole variety of myeloma cells, but there's one that's gonna dominate, and it's going to be calling the shots. And every other cell, or the majority of the other people or cells, are gonna follow suit. If we give a treatment that destroys the leader, then somebody else is gonna take the lead position. And it could be the mean one, or the bitter one, or the one that doesn't care, or the easygoing. So if you have an easygoing, that might be sensitive to that treatment again. So it's worth checking. But it's always important to try to determine how effective it was and how long it lasted. And if you don't have any other options, give it another try.
That was a better explanation.
On the left side of your packets, there's one of the sheets in there is on Spark Cures, who partners with HealthTree. So when you go to HealthTree and learn about clinical trials, you're basically going to Spark Cures, and they're going to give you some counseling. I would highly encourage you to use it. It was started by a young man whose mother was a nurse practitioner who treated myeloma patients who herself had an aggressive case of myeloma, and the frustration that they had in finding clinical trials for her caused him to do this project. He now has a staff, he has counselors, so they will, if you have questions, you can call them up. They will put you together with staff people that are running various clinical trials around the country, and then you can ask them questions just like the one you just asked.
Okay, in Georgia, good general diet. Okay, there we go. All right, so let's move on to the microbiome. The microbiome, there was a high-impact publication, came out probably about 6 months ago, and basically showed that the so-called probiotics that they had people eat, and then they monitored their changes in the microbiome, it was completely nonsensical. Nothing that went in, nothing related to what went out, and they realized that this is complete crap. Haha. And but in truth, but it did kind of show a direction for future research in that if you could target what is ingested to fit with the patient's existing microbiome, then you could absolutely have an influence, make some difference, but we're nowhere near being able to make patient-specific microbiome therapies. But clearly that publication kind of showed the runway of where it's going to go.
So I think you're going to be hearing about microbiome a lot in the next years because I feel like this is going to be the new novel thing to look at. Immunotherapy has been the rage for the last 5 years or so, and I think that microbiome is going to be the new trend, and who knows if it's going to be good or not. And I can give you an example that has nothing to do with myeloma, but lung cancer. I think there's more data on microbiome with lung cancer and how sometimes the gut flora is affecting drug resistance. And the reason why that is in lung cancer is that there's sometimes some gut flora in your gut that causes inflammation. And if you have a lot of inflammation in your gut and you're taking a pill to treat your disease, the inflammation might not allow the medicine to be absorbed properly. And therefore, you don't have enough drug in your body so that you can control the cancer or kill the cancer. That's one thing that has been seen, at least in lung cancer. And there's other things that they've noticed with the gut flora in lung cancer. But in myeloma, we're a few steps behind, just like we were with monoclonal antibodies and immunotherapy. A lot of the things that have been identified in solid tumors doesn't necessarily translate to multiple myeloma. And we've seen it in immunotherapy a lot. CAR T therapy is not as effective like lymphoma and leukemia. The PD-1 inhibitors, it hasn't been that great in myeloma yet, like in solid tumors. So there's a possibility that there might be something for us in the near future, but there's still a lot of investigation that needs to be done. So they work the same.
Okay.
If you're resistant to one, you're not going to have an added benefit with this tuximab or vice versa. It does. So there's two new IMiDs that they're labeling them or promoting them as cell mods. They're slightly different than the lenalidomide and the pomalidomide in terms of how effective they are. And the studies that they've done on the iberdomide in people who have had lenalidomide or pomalidomide, they're showing that they're showing some responses because it's targeting a different path. And the other cell mod that is being developed also has a completely different target area or path. So it all depends on where they attach to and the mechanism of the cell, the cancer cell, whether they're going to have the same resistance to previous drugs or not. And these are targeting different areas, or what we call epitopes. But I'll let the rest of the colleagues elaborate more on that. These are drugs that are under study right now. They're still not FDA approved. But I'm very positive that they're going to be studied in combination, just like the other IMiDs have been studied and approved for combination.
CBD oil is legal in Minnesota. I mean,
I got mine from Asheville, North Carolina.
so I'm not aware of any studies about CBD oil in myeloma. A lot of my patients take it to try and ameliorate, to attenuate symptoms associated with therapy, headaches, nausea. I don't know what else to say if they say, I take it, I feel better. So, you know, I don't know. I would advise you not to vape it. And you have stable liver lesions that we don't even know what the liver lesions are, so I don't know what that means, you know? Yeah, Kaufman knows.
Yeah, I think, so CBD oil, there's a lot of claims. I also have a lot of patients who take it. I have some patients that helps them in a variety of things. It comes in a very small vial and it's sort of expensive, right? It's really expensive. So it's expensive. That's what I know about it.
Just if anybody's got, because I don't think anybody has an answer as to what it does to myeloma or not. But if you guys are going to try it or use it, please let your doctors know about it, because it could interfere or interact with other medicines that you're taking. And also, it could alter liver enzymes, so just make your doctor aware of it. So there was a paper that was published this summer suggesting that people who were taking CBD oil, there was a percentage of them who were having changes in their liver enzymes. But it's not sure if it's caused by the CBD oil or other medicines that they were on.
A
So,
good change or a bad change?
bad change, elevation in the liver enzymes. But we don't have enough information to know, yes, CBD oil is going to damage your liver, or CBD oil is going to screw up with other medicines that you're taking. So just let your doctors know so that they can talk to the pharmacist, and then they can look at it, read about it, and then come back and say, we don't know.
The vast majority of patients who develop a plasma cell disorder or myeloma don't have a specific cause. There's a variety of environmental exposures where there's not been patient-level data, but population-level data where we suspect it's related. And so I would say that we're unable to identify the vast majority of causal agents for myeloma.
You don't think that the Emory practice, located in Delta's largest hub, might kind of enrich your practice for pilots?
I have a handful of pilots, but I will tell you that, and you're the same way. We fly a lot, right? You fly a lot.
Yes.
You ever see the same pilot twice?
No.
No, there's a lot of pilots, and there's not a lot of myeloma patients.
Yeah, so Camp Lejeune is actually the water from the well is contaminated, and the government has already determined that there is a correlation of people who were in Camp Lejeune from, I think it's 1985 until 1990 something.
1953 to 1987.
And if you were at Camp Lejeune for more than 4 months, then you need to contact either the VA or whoever you worked with at that time, because there is.
What's it contaminated?
I don't know. I'm not privy to that.
Dioxin? Yeah?